Welcome. In this session, we'll be discussing about Vitreomacular Traction syndrome and full thickness macular hole, which, as we shall see, are considered to lie in the same spectrum pathogenetically and whose classification and staging overlap. Vitreomacular traction or VMT syndrome is a vitreomacular interface disorder which occurs due to an anomalous posterior vitreous detachment, which we have discussed in the previous session. VMT syndrome is characterized by an incomplete posterior vitreous detachment in the perifoveal area, as seen here in each of these four OCT images, with persistent residual attachment of the posterior vitreous cortex at the center of the macula, usually within a radius of 3000 microns from the foveal center, along with anteroposterior traction induced by the syneretic vitreous on the center of the macula at this attachment site. VMT syndrome can itself cause visual decline in the form of loss of visual acuity and/or metamorphosia, or lead to complications such as full thickness macular hole, which we'll be discussing later in this session, tractional macular schisis, and macular or foveal detachment. International VMT study group has classified vitreomacular interface anomalies based on OCT into vitreomacular adhesion, vitreomacular traction, and full thickness macular hole. Vitreomacular adhesion or VMA is defined as the presence of all of the following features in at least one OCT scan image: incomplete posterior vitreous detachment in the perifoveal area, along with persistent attachment of the posterior vitreous cortex to the retinal surface within a radius of 3000 microns from the foveal center, and an acute angle between the detached posterior vitreous cortex and the inner retinal surface. In contrast to vitreomacular traction syndrome, in vitreomacular adhesion, the foveal contour and anatomy is otherwise normal, along with a normal visual function. Vitreomacular adhesion may progress to vitreomacular traction and then to full thickness macular hole, and if there is a full thickness macular hole in one eye, vitreomacular adhesion in the fellow eye corresponds to stage 0 in the classification system for full thickness macular hole, which we'll be discussing later in this session. Vitreomacular traction or VMT is defined as the presence of all of the following features in at least one OCT scan image: incomplete posterior vitreous detachment in the perifoveal area with persistent attachment of the posterior vitreous cortex within a radius of 3000 microns from the foveal center, and an acute angle between the detached posterior vitreous cortex and the inner retinal surface. In contrast to vitreomacular adhesion, in vitreomacular traction, the foveal contour and anatomy is abnormal and may take the form of macular thickening, foveal pseudocyst, macular schisis, and foveal detachment, along with reduced or distorted vision. This OCT image shows perifoveal posterior vitreous detachment with persistent attachment of the posterior vitreous cortex to the center of the macula, pseudocysts in the retina, along with a foveal detachment. In contrast to full thickness macular hole, vitreomacular traction is characterized by an absence of a full thickness defect of the retina at the fovea, but as we shall see, vitreomacular traction can progress to a full thickness macular hole, and vitreomacular traction corresponds to stage 1 in full thickness macular hole classification system. Both vitreomacular adhesion and vitreomacular traction are further described as either focal or broad, and either isolated or concurrent. In focal VMA or VMT, the width of vitreoretinal attachment zone is less than or equal to 1500 microns, and in broad VMA or VMT, the width of vitreoretinal attachment zone is more than 1500 microns, and a smaller vitreoretinal attachment zone produces a higher tractional stress on the retina. Concurrent VMA or VMT occurs in the setting of other entities such as diabetic macular edema, retinal venous occlusion, and neovascular AMD, and in concurrent VMA or VMT, cellular proliferation induced by the associated maculopathy occurring over the posterior vitreous cortex promotes the anteroposterior traction. Prevalence of isolated VMT syndrome is 22.5 per 100,000 individuals, and when both isolated and concurrent VMT syndrome are considered together, the prevalence is around 1.5%, and 70% of fellow eyes of eyes with VMT are found to have some form of vitreoretinal interface abnormality. As we have mentioned, Vitreomacular adhesion is asymptomatic and vitreomacular traction is symptomatic and can cause blurred or reduced vision, metamorphopsia, micropsia, and scotoma. The onset and progression of symptoms in vitreomacular traction is gradual, but in a few cases there can be a sudden deterioration of vision with onset of scotoma due to occurrence of a foveal detachment. On slit lamp biomicroscopy in an eye with VMT, sometimes a faintly visible translucent glistening and taut membrane with adhesion to central macula may be discerned, and associated features include cystoid spaces in the fovea, macular pucker or epiretinal membrane, tortuosity of retinal vessels around the fovea, macular or foveal detachment, and signs of associated maculopathy if any. As we have mentioned, OCT in eyes with VMT shows perifoveal posterior vitreous detachment with persistent attachment of the posterior vitreous cortex to the center of the macula, and the detached posterior vitreous cortex in the perifoveal area appears as a thickened hyperreflective line. Associated OCT features in eyes with VMT include blunting or distortion of the foveal contour, pseudocysts in the retina, which may occur in up to 80% of eyes with VMT, disruption of the inner and or the outer retinal layers, epiretinal membrane, which has been reported in up to 40 to 100% of eyes with VMT, and complications of VMT such as full thickness macular hole, tractional macular schisis, and macular or foveal detachment. Focal VMT are more commonly associated with intraretinal cysts or pseudocysts, foveal detachment, and impending macular holes, whereas broad VMT are more commonly associated with diffuse retinal thickening. Focal and isolated VMT usually shows no leakage on fluorescein angiography despite the presence of intraretinal pseudocysts on OCT, but leakage on fluorescein angiography may be found in eyes with broad VMT and in eyes with concurrent VMT due to the associated maculopathy. An UHG-B scan may show the partial PVD attached to the fovea. Ikichi et al. Based on slit lamp biomicroscopy showed that over 5 years of follow-up, almost 2/3 of VMT patients had deterioration of 2 or more Snellen lines of visual acuity, and around 10% of VMT patients had spontaneous resolution with detachment of the posterior vitreous cortex from the center of the macula, with improvement in visual acuity and resolution of cystoid changes. Based on optical coherence tomography, John et al. Showed that over 23 months of follow-up among VMT patients with or without intraretinal cysts but without foveal detachment, spontaneous resolution occurred in 30% of eyes, whereas worsening of OCT features occurred in around 15% of eyes. But among VMT patients with both intraretinal cysts and foveal detachment, spontaneous resolution occurred in 57% of eyes, whereas worsening of OCT features occurred in 28% of eyes. This implies that the higher the grade of vitreoretinal traction in VMT, the higher the chance of spontaneous resolution and the higher the risk of deterioration as well. Spontaneous resolution of VMT has been found to be less common in eyes with broad VMT and in VMT eyes with associated epiretinal membranes, and on comparison with eyes with only epiretinal membranes, eyes with VMT have a higher rate of progression. Epiretinal membranes, which we have discussed in the previous session, progress infrequently. As we have mentioned earlier, complications of vitreomacular traction include full thickness macular hole, tractional macular schisis, and macular or foveal detachment. Differential diagnosis of VMT include cystoid macular edema, epiretinal membrane, and early full thickness macular hole. Indications for vitrectomy in eyes with VMT include significant symptoms with evident VMT on OCT. On the other hand, patients with no or mild symptoms and less severe signs of VMT on OCT do not require surgery but should be periodically monitored to detect signs of deterioration as and when it occurs. Eyes with vitreomacular traction require pars plana vitrectomy with release of vitreomacular as well as vitreopapillary adhesions with or without removal of ILM and associated ERM and gas tamponade. Visual acuity improvement by 2 or more needle lines have been reported in 45 to 100% of these patients, but functional improvement with restoration of inner and outer retinal layers can take more than 12 months to occur. Focal vitreofoveal attachment, shorter duration of symptoms, better preoperative visual acuity, tractional cystoid spaces within the retina, and lower preoperative retinal thickness are associated with better post-operative visual prognosis. On the other hand, macular schisis, foveal detachment, epiretinal membrane, and chronicity are associated with poorer post-operative visual prognosis. An important complication of pars plana vitrectomy in these eyes is the occurrence of a full-thickness macular hole. Vitreolysis with either intravitreally administered drug or gas is a treatment alternative for eyes with vitreomacular traction and full-thickness macular hole. Intravitreal ochriplasmin, a recombinant truncated form of human plasmin, was approved for use in eyes with vitreomacular traction and full-thickness macular hole. And in phase 3 and phase 4 studies with this drug, release of vitreomacular attachment occurred in 26.5% of patients and in 45.8% of patients being injected with this drug respectively. Eyes with focal vitreomacular attachment and without coexisting epiretinal membrane had a higher success rate with this drug. But several adverse events, including occurrence of full-thickness macular hole, dehiscence of ellipsoid zone on OCT, ERG changes, and zonular dialysis, have been reported following administration of this drug, and the drug was later withdrawn from the market. Pneumatic vitreolysis involves intravitreal injection of 0.3 ml of C3F8 followed by prone positioning, and following this procedure, release of vitreomacular attachment has been reported to occur in as many as 86% of patients. And risk of full-thickness macular hole and of retinal detachment in addition are also associated with this procedure. A full-thickness macular hole or FTMH is a full-thickness retinal defect at the foveal center as seen here in this clinical photograph. Most FTMH are primary or idiopathic, occurring in the absence of any other ocular conditions, and infrequently secondary FTMH can occur in conditions such as myopia and following blunt ocular trauma, which we will be discussing later in this session. Prevalence of idiopathic macular holes has been reported to be up to 3.3 per thousand individuals, and this prevalence is higher than the prevalence of idiopathic VMT because diagnosis at the stage of idiopathic VMT occurs much more infrequently. Bilateral full-thickness macular holes has been found in 5 to 16% of affected individuals, and incidence of full-thickness macular hole in fellow eyes of eyes with full-thickness macular hole have been reported to be 20% after a mean follow-up of about 3 years. Importantly, incidence was higher in fellow eyes with vitreomacular traction at baseline as compared to fellow eyes with vitreomacular adhesion at baseline, but no fellow eyes with an already existing posterior vitreous detachment from the macula developed full-thickness macular hole later, and this is important to remember. Idiopathic full-thickness macular holes usually occur in the 7th decade of life or later, and females are affected twice as more commonly as males. An idiopathic full-thickness macular hole can occur due to either or a combination of the following: anteroposterior traction from a pre-existing vitreomacular traction, which we have discussed earlier in this session, or tangential traction from an epiretinal membrane, or the attached posterior lamella of the posterior vitreous cortex following vitreoschisis. Currently, anteroposterior traction from VMT is presumed to be the underlying causative factor for the majority of idiopathic full-thickness macular holes, and this is very important to note. Symptoms of full-thickness macular hole include decreased visual acuity, central scotoma, and metamorphopsia, and these occur due to retinal dehiscence within the hole and localized detachment and cystoid changes in the retina surrounding the hole. A well-developed full-thickness macular hole, will be defining the stages of macular hole later in this session, appears on ophthalmoscopy as a red-colored round defect in the retina with smooth margins at the foveal center, often with a grayish ring of slightly elevated retina with cystic changes surrounding the defect. Yellowish nodular deposits may be found in the base of the defect, and pigment alteration of retinal pigment epithelium within and surrounding the defect can occur in long-standing macular holes. An operculum can be clinically detected anterior to 25% of full-thickness macular holes, and they are called pseudooperculum because they usually contain glial tissues and rarely contain neural tissue. An epiretinal membrane can be detected clinically in 40% of eyes with full-thickness macular holes, and the Wadsky-Allen sign may be elicited in a patient with a full-thickness macular hole, in which, when a thin vertical slit beam is projected and centered on the macular hole, the patient will perceive a discontinuity in the center of the projected line corresponding to the macular hole. In contrast to patients with full-thickness macular holes, patients with epiretinal membranes, macular pseudoholes, and inner lamellar macular holes may perceive distortion in the center of the projected line but will not report discontinuity. Optical coherence tomography in a stage 2 or higher full-thickness macular hole will show a full-thickness retinal defect in the foveal center with a zone of bare retinal pigment epithelium, thickened and elevated edges of the retinal defect, often with intraretinal fluid and cysts, and subretinal fluid, and a posterior vitreous cortex which may be attached at the edges of the retinal defect at the optic disc or may be completely detached. An operculum may be detected in the posterior vitreous cortex anterior to the defect. Prior to the onset of a full-thickness macular hole, a foveal crack sign is considered as a predictive biomarker of progression to full-thickness macular hole. This sign consists of thin hyperreflective vertical lines in the foveal center, which are regarded as stressed Muller cells connecting the internal limiting membrane and the external limiting membrane. Prior to surgery for correcting full-thickness macular holes, OCT can detect signs which predict the risk of persistence or recurrence of full-thickness macular hole following surgery. These include large macular holes, myopic holes with posterior staphyloma, chronicity of holes, and indices which predict closure of the macular hole, such as macular hole closure index, which is the sum of the photoreceptor arms at the hole edges divided by the basal diameter of the hole. Following surgery for full-thickness macular hole, OCT can determine anatomic closure of the hole, and this post-operative OCT scanning can be performed through gas bubble or silicone oil as early as the first post-operative day and can thus guide head positioning regimen early after surgery. Swept source OCT is considered to be more efficient for this purpose. Closure of FTMH can usually be detected within 1 to 3 days following surgery, and OCT can determine cause of suboptimal visual gain post-operatively despite anatomic closure, such as abnormalities in the photoreceptor layer. On the optical coherence tomography, the macular hole diameter is measured as the narrowest hole width along a line parallel to the retinal pigment epithelium as shown by this red line. And an epiretinal membrane is often found in eyes with full-thickness macular hole, and the incidence of epiretinal membrane increases with the size, stage, and duration of the full-thickness macular hole. Two staging or classification systems of full-thickness macular holes need to be considered. The original staging system was developed by Gass based on slit lamp biomicroscopy when OCT was not available, and this staging system is still widely used clinically. Gass's interpretation of the clinical signs was based on the understanding that tangential vitreomacular traction caused full-thickness macular holes. Corresponding OCT features of each of these stages, which have changed our understanding of the pathogenesis of full-thickness macular holes, chiefly anteroposterior vitreomacular traction, will be discussed simultaneously. Stage 0 macular hole was not included in Gass's original staging system, and it describes a normal foveal appearance clinically with a normal visual function, with OCT showing a perifoveal or posterior vitreous detachment but with a normal foveal contour in the fellow eye of an eye with full-thickness macular hole. So stage 0 macular hole corresponds to vitreomacular adhesion stage in the International Vitreomacular Classification System. In stage 1 or impending macular hole, a full-thickness retinal defect is yet to occur, and thus it corresponds to Vitreomacular Traction entity of the International VMT Study Group classification. Stage 1 macular hole is further subdivided into Stage 1A and Stage 1B macular hole. Stage 1A macular hole is clinically characterized by a small yellow spot in the foveal center with visual acuity declining to the range of 20/25 to 20/60. OCT in Stage 1 macular hole shows perifoveolar posterior vitreous detachment with posterior vitreous cortex attached to the fovea along with foveal pseudocysts and or foveolar detachment. Stage 1B macular hole is clinically characterized by the presence of a yellow ring in the fovea with visual acuity declining to the range of 20/25 to 20/60. OCT in Stage 1B also shows perifoveolar posterior vitreous detachment with the posterior vitreous cortex attached to the fovea along with foveal cyst and or foveal detachment, but in addition there is a break in the photoreceptor layer, the margin of which is said to correspond to the yellow ring seen clinically. So OCT in Stage 1A and Stage 1B macular holes do not show a full thickness retinal defect and thus corresponds to the Vitreomacular Traction entity of International VMT Study Group classification. In Stage 2 macular hole, a full thickness retinal defect less than 400 micron in diameter is detected due to formation of a tractional break in the roof of the foveal pseudocyst. Stage 2 macular holes appear clinically as either an eccentric, oval, crescent or horseshoe-shaped retinal defect as seen here in this photograph, or as a central round retinal defect along with a further decline in visual acuity to the range of 2050 to 2400. OCT in Stage 2 macular hole shows a full thickness retinal defect due to partial opening of the roof of the foveal pseudocyst, often with an operculum attached to the edge of the roof of the defect and with the posterior vitreous cortex still remaining attached to either the operculum or to the edge of the roof of the defect. Stage 3 macular hole clinically appears as a central round full thickness retinal defect 400 micron or more in diameter with a rim of thickened and elevated retina as we have discussed previously, but without a Weiss ring in front of the optic disc. The visual acuity reduces further in Stage 3 macular hole commensurate with increasing hole diameter to the range of 20/200 to 20/800. OCT in Stage 3 macular hole shows a full thickness retinal defect along with detachment of the posterior vitreous cortex from the macula but still remaining attached to the optic disc. Stage 4 macular hole clinically appears similar to Stage 3 macular hole but with a Weiss ring in front of the optic disc with the visual acuity in a similar range of 20/200 to 20/800. OCT in Stage 4 macular hole shows a full thickness retinal defect with the posterior vitreous cortex detached from both the macula and the optic disc and often not visible. The second classification system of full thickness macular hole is by the International VMT Study Group based on optical coherence tomography. According to size, full thickness macular holes are classified as small, medium or large. According to status of vitreomacular attachment, full thickness macular holes are classified as with an attached posterior vitreous cortex or without an attached posterior vitreous cortex, and according to the cause, full thickness macular holes are classified as primary, which are caused by vitreomacular traction, and as secondary, which are unrelated to vitreomacular traction. This table shows the correspondence between clinical staging as described by Guess and OCT-based staging as described by the International VMT Study Group. Nearly 50% of Stage 1 macular holes undergo spontaneous resolution and up to 10% of Stage 2 macular holes may undergo spontaneous closure, but all Stage 3 macular holes progress to Stage 4 with none undergoing spontaneous resolution. Differential diagnosis of full thickness macular holes include macular pseudohole, inner lamellar macular hole, and epiretinal membrane. Surgical repair is indicated for Stage 2 or higher full thickness macular hole, but Stage 1 macular holes may be observed as 50% may undergo spontaneous resolution. Vitrectomy itself can induce a full thickness macular hole, and because Stage 2 macular holes have a high rate of closure following surgery. Vitreomacular attachment to the edge of the hole, which induces anterior traction on the retina, is not present in most full-thickness macular holes presenting clinically, so in addition to vitrectomy, tangential tractional force on the retina induced by internal limiting membrane or by an epiretinal membrane if present need to be relieved for achieving hole closure. Gas tamponade is a crucial component of surgery for macular holes, and the gas bubble seals the macular hole and dehydrates the edges of the hole to enable closure of the hole. Surgical procedure for full-thickness macular hole includes extensive vitrectomy, induction of posterior vitreous detachment with the posterior hyaloid, which can be stained with triamcinolone, being separated from the posterior pole up to the equator, removal of epiretinal membrane, which can be stained with trypan blue, and peeling of internal limiting membrane in a circular area over and around the fovea. Internal limiting membrane can be stained with brilliant blue G dye, and internal limiting membrane peeling, which has significantly increased the anatomical closure rates of larger macular holes, is now considered as a crucial step in the surgical treatment of full-thickness macular holes. An inverted internal limiting membrane flap can be used as an adjunct in very large macular holes and in myopic macular holes. In this procedure, the peeled ILM flap, instead of being detached from the fovea, is kept attached at the edge of the hole, a portion of the ILM flap removed, and the ILM flap is then used to cover the macular hole. Used in this way, the ILM flap is supposed to act as a scaffold for closure of the macular hole. This series of OCT images, taken 1 month, 6 months and 12 months post-operatively, shows the result of using an inverted ILM flap for closing a full-thickness macular hole. Other adjuvants which have been suggested to close larger holes, myopic holes, chronic holes and recurrent holes include autologous platelet concentrates and amniotic membrane. Gas tamponade following internal limiting membrane peeling is a critical component in the surgical procedure for full-thickness macular holes. Smaller holes may be closed with 20% sulfur hexafluoride, but larger holes require 14% perfluoropropane. We have discussed the usage of intraocular gases in the session on retinal detachment. Following surgery for full-thickness macular hole, post-operative head positioning is important, and the patient is advised to avoid supine position for at least a week. Face-down positioning has been shown to be not required if the macular hole is small and the gas bubble is large enough for adequate gas fovea contact irrespective of head position during the initial post-operative period. As with vitreomacular traction, vitreolysis, either pharmacologic or pneumatic, has been attempted to correct full-thickness macular holes, but these procedures do not work for larger macular holes and for macular holes without vitreomacular attachment. Following surgery, closure of full-thickness macular hole occurs due to glial cell proliferation, and this is important to remember. These OCT images show various patterns of macular hole closure following surgery, and this OCT image shows non-closure of full-thickness macular hole following surgery. This OCT image, as we have discussed previously, shows usage of an inverted ILM flap, and this OCT image shows usage of a free ILM flap. Rate of anatomical closure of full-thickness macular hole, defined as reapproximation of hole edges on OCT covering the retinal pigment epithelium, has been reported to be 92% to 97% with ILM peeling and 77 to 89% without ILM peeling. 5% of successfully closed holes may reopen even years later, often following cataract surgery or yak capsulotomy. Mean post-operative visual acuity has been found to be 20/40, with 58% achieving visual acuity of 20/40 or better. Larger and long duration macular holes have poor outcomes following surgery. The two common causes of secondary macular holes are high myopia and blunt ocular trauma. Macular holes in high myopia typically occurs in eyes with posterior staphyloma, as seen here in this OCT image, and is usually preceded by a foveoschisis, as seen here in this OCT image, which may be asymptomatic. We have discussed about myopic foveoschisis in a previous session. Macular holes in highly myopic eyes may be difficult to detect clinically because of associated myopic chorioretinal degeneration, and in contrast to idiopathic macular holes in highly myopic eyes typically occur at a younger age. This OCT image shows a macular hole with retinal detachment in a highly myopic eye with posterior staphyloma. This OCT image also shows macular hole in a highly myopic eye with posterior staphyloma along with foveous cases. Unlike in eyes with idiopathic macular holes in eyes with high myopia often leads to retinal detachment extending beyond the macula, and this is very important to remember. Macular holes in highly myopic eyes have a poorer anatomical and visual prognosis following surgery because of the retinal stretching required to close the macular hole within a deep posterior staphyloma. Blunt ocular trauma can also cause a secondary macular hole by inducing sudden axial compression and equatorial expansion, which stretches the retina, creating a rupture of the retina at the fovea, and this type of macular holes typically occur in children and young adult males. In these eyes, posterior vitreous cortex usually remains completely attached to the posterior pole, and these eyes may also demonstrate other sequelae of blunt ocular trauma such as choroidal rupture, commotio retini, and peripheral retinal breaks. Traumatic macular holes can spontaneously close, and surgical repair of traumatic macular holes is usually successful. Other causes of secondary macular holes include electric shock, laser pointed exposure, Nd:YAG laser and vitrectomy, hereditary diseases, uveitic entities, and retinal vascular diseases. To recap the salient points, vitreomacular traction occurs due to an anomalous posterior vitreous detachment in which the posterior vitreous cortex is detached from the perifoveal area but remains attached to the center of the macula, exerting anterior traction on the retina at the site of this vitreoretinal attachment at the center of the macula. International VMT study group classified this group of entities based on OCT into vitreomacular adhesion in which the foveal contour and visual function remain normal, vitreomacular traction in which the foveal appearance is abnormal, usually with a concomitant decrease in visual function, and full thickness macular hole in which there is a full thickness defect of the retina in the foveal region. Both vitreomacular adhesion and vitreomacular traction can be either focal or broad and either isolated or concurrent with other maculopathies. Vitreomacular adhesion can progress to vitreomacular traction and finally to full thickness macular hole. Vitreomacular adhesion, vitreomacular traction, and early full thickness macular hole can also undergo spontaneous resolution with separation of the posterior vitreous cortex from its attachment at the center of the macula. Surgery for vitreomacular traction is required when there are significant symptoms in the presence of significant VMT on OCT. Surgery involves pars plana vitrectomy with release of vitreomacular attachment and gas tamponade. Vitreolysis, either pneumatic or pharmacological, are alternatives to pars plana vitrectomy which are particularly effective for focal VMT. An important complication of all these treatment modalities in this scenario is the occurrence of full thickness macular hole. An idiopathic or primary full thickness macular hole is a full thickness defect of the retina in the center of the macula, which usually occurs due to anterior traction from vitreomacular traction but can also occur due to tangential traction from an epiretinal membrane or the posterior lamella of posterior vitreous cortex following vitreous cases. Patients with full thickness macular holes complain of blurred vision and/or metamorphopsia. On ophthalmoscopy, a fully developed full thickness macular hole appears as a round reddish colored defect in the fovea with smooth margins and often with a rim of thickened and elevated retina surrounding the defect. Yellowish deposits may be seen on the retinal pigment epithelium within the macular hole. The patient may perceive a discontinuity in the center of a vertical thin linear beam of light projected and centered on the macular hole, which is called the Watsky-Allen sign. Long-standing full-thickness macular hole can develop atrophy of retinal pigment epithelium and demarcation lines at the leading edge of the subretinal fluid. Gas described the stages of idiopathic full-thickness macular hole based on slit lamp biomicroscopy. Stage 0 macular hole corresponds to vitreomacular adhesion on OCT in the fellow eye of an eye with full-thickness macular hole. Stage 1 macular hole corresponds to vitreomacular traction on OCT. Stage 1A clinically appears as a yellow spot in the foveal center which corresponds to a foveal cyst and or a foveal detachment on OCT, and stage 1b macular hole appears clinically as a yellow ring in the foveal center, which corresponds to the development of a discontinuity in the outer retinal layer on OCT. Stage 2 is characterized by a full thickness retinal defect, central or eccentric, less than 400 microns in diameter, which shows a corresponding full thickness retinal defect on OCT, but with the posterior vitreous cortex still remaining attached to the edge of the hole. Stage 3 macular hole is characterized by a central full thickness retinal defect, 400 microns or more in diameter, with the OCT showing a corresponding full thickness retinal defect, with the posterior vitreous cortex detached from the center of the macula but remaining attached to the optic disc. Stage 4 is characterized by a central full thickness retinal defect, more than 400 microns in diameter, with the OCT showing a corresponding full thickness retinal defect, with the posterior vitreous cortex detached from both the center of the macula and the optic disc. International VMT study group classified full thickness macular hole based on size, status of vitreomacular attachment, and cause as primary full thickness macular hole occurring due to vitreomacular traction, and secondary full thickness macular hole occurring due to other causes. Spontaneous resolution of macular holes with separation of posterior vitreous cortex from the center of the macula can occur in 50% of eyes with stage 1 macular hole and in 10% of eyes with stage 2 macular hole, but all patients with stage 3 macular hole progress to stage 4. Surgery is indicated for stage 2 or higher full thickness macular hole. Surgery involves pars plana vitrectomy, removal of epiretinal membrane if any, internal limiting membrane peeling, gas tamponade, followed by post-operative positioning. Internal limiting membrane peeling and maneuvers such as inverted internal limiting membrane flap are particularly important for large and chronic macular holes and holes in highly myopic eyes. Anatomic closure has been achieved with these techniques in 95% or more of patients, but visual recovery is more guarded. Anatomic closure of full thickness macular holes following surgery occurs by proliferation of glial cells. More than 50% of eyes undergoing surgery for full thickness macular holes achieve a visual acuity of 20/40 or better, but larger and long-standing full thickness macular holes have a poorer visual prognosis. Alternatives to pars plana vitrectomy include vitreolysis, either pharmacologic or pneumatic, but these methods are effective only in eyes with small full thickness macular holes with persistent vitreomacular attachment. Full thickness macular holes can also be secondary, such as following blunt ocular trauma or in highly myopic eyes with posterior staphyloma. Thank you for listening.